But as of now, we are able to contact with only two, Dr. J.K. Basu and Dr. Arup Kumar Das. If in the meanwhile both of them come, you can adjust them and you can decide the time based on this.
So this session is of how many time? Half an hour or?
1 hour, sir. 1 hour.
1 hour.
1 hour for 4
have
papers.
lot of time.
But yeah.
Arup?
Welcome.
Good morning, sir.
Good morning.
Good to see you after a long time. बहुत दिन बाद मिले सर.
Good morning. और सब ठीक है?
हाँ सर, आप सब ठीक है? तबीयत वगैरह ठीक है सर?
हाँ, एकदम फर्स्ट क्लास है.
ओके सर.
घर में बंद है बस.
सब लोग बंद है.
चलिए, खान साहब, we just start it, ना?
Yes, sir, please.
हाँ.
So you're live.
Where is J.K. Ghosh?
JK is here.
Basu, I am here, sir.
J.K. Basu. Basu is here.
Maybe in the videos.
बासु साहब तो बहुत स्मार्ट लग रहे हैं.
अरे नहीं सर, यू आर सर, आप हमसे भी ज्यादा स्मार्टर हैं. हम कुछ
Sir, for a while I got confused with Anupam Kher. I thought suddenly Anupam Kher is a
right.
Thanks for the compliment, KVS.
चलिए, खान साहब तो शुरू कर दीजिए एक आदमी से and give him enough time to because only two of them is here. So start with 20 minutes, right?
Yes, sir. Yes.
Okay. So who is going to present first?
Sir, as for the seniority, I think if Arup don't mind, we start with Dada.
Right. Go ahead.
Yes, sir.
Okay.
Thank you.
So I have to follow the same thing for sharing screen, or it is already there?
No. You have to do it again.
I have to do it again. Okay.
हाँ, हो गया. अभी फुल स्क्रीन कर दीजिए.
फुल स्क्रीन तो कर दिया. हाँ,
ठीक है.
अच्छा.
So it is
okay. So shall I start?
Yes, sir. Yes.
Okay.
Sir, just start it.
So once again, good morning to all of you, and my sincere thanks to IASP for allowing me to give this talk, and thanks to Professor K.K. Singh and Professor A.G. Khan and KVS also. Nice to meet all of you. I will just talk on just a second. I'll just talk on the measuring of excess mortality during the COVID-19 pandemic, particularly in India. The need for a mobile phone survey. Basically, it is not anything I am going to talk on survey-based data or talking on any data analysis or anything. This is just while reading some of the documents and reviewing some of the literature, looking into how the other countries are doing. And particularly in Australia, I found this is they are using it randomly, this thing. So I felt that let us discuss this and how to go ahead with that. This is the kind of thoughts based on certain observation and literature review. And in the law, particularly in a snapshot, what I would like to say that in the low or middle income countries, particularly like India or so. Just a second. I want to get rid of this video. In low and lower middle income countries, particularly like India or Indian subcontinent, data from the civil registration system do not allow monitoring of excess mortality during the COVID-19 pandemic. That's why while I'm working with the University of Melbourne, then I found that they are estimating the excess mortality. Even in they had a presentation, a webinar in IASP also, and there also they talked of the measuring of excess mortality due to COVID-19 pandemic. But whenever we come to India, or Indian subcontinent area, then we found that we are handicapped. We do not have proper civil registration data, particularly on the date registration data, and even the MCCD measurement of cause of death or mortality due to cause of death. That recording, as per WHO classification, is only in case of 20 to 22%. So, under such situation, what to do? The rapid mobile phone service aimed at measuring the mortality trends on monthly basis, area realistic and safe option for filling that data gap. And the data generated by mobile phone service can play a key role in a better targeting the areas or population groups most affected by the pandemic, because we do not have the facility to test everyone, and maybe testing facility is limited and restricted to certain areas also. So we may not be able to track the population most at risk, or the vulnerable population groups. So this could help in that situation. Also, they can help monitor the impact of the intervention and programs and rapidly identify what works in mitigating the impact of COVID-19. So to introduce the one is the monitoring mortality is an essential component of effective response to the COVID-19 pandemic, we all know. And COVID-19 surveillance system around the world count primarily deaths occurring in the hospitals and to individuals who tested positive. Particularly in low and lower middle income countries like India, the surveillance systems usually undercount the number of deaths. And particularly due to COVID-19, there is no such facility. But civil registration and vital statistics system are insufficiently complete to fill these data gaps. So we have a system to track, or we can only record the deaths occurring due to COVID-19 in the hospital or facility based. But there are a lot of deaths and cases outside the facility based. How to track them? Instead, here the researchers often use the models to assess what effects an epidemic might have on mortality, particularly in such countries. And reduced healthcare utilization during the COVID-19 pandemic could thus have large effects on maternal and child health, and also HIV/AIDS mortality like that. So, thought of doing a kind of interim tools are needed to assess excess mortality due to COVID-19. Surveys that constitute primary sources of mortality data are very infrequent for that purpose in India and in Indian subcontinent countries. These in-person inquiries also pose significant health risks that we all agree, and almost it is not being done at the moment. And they involve is a face-to-face interaction with several respondents, which put everyone at risk. So in such situation, a mobile phone service, MPS, represent the most viable alternative approach to safely generating timely data on excess mortality. So in this paper particularly suggests different approaches of measuring excess mortality using the mobile phone service. So several consideration in the planning of mobile phone service aimed at measuring the excess mortality during COVID-19 pandemic period were reviewed and by extensive desk reviews or literature and secondary data. So basically, when I found this thing is randomly used in countries like Australia, then I felt that I just requested them to share me with some literature so that I can review, and basically based on that, these thoughts are being presented today. So there are some approaches. One is that how will the participants be selected? So mortality MPS could select participants from list of valid phone numbers obtained either from the mobile phone operators
No voice is coming.
Need to contact potential.
No.
Hello,
Yeah,
hello,
now clear, now clear.
clear. Okay. So if list of valid numbers are not available by any chance, surveyors might need to contact potential respondents using random digit dialing procedure, etc. And in some of the settings, the mobile MPS participants could also be sampled from the registries of beneficiaries maintained by NGOs and other sources also. And which questions should be asked to measure? It should be a short survey. So mortality MPS could build on standardized instruments used during the in-person surveys, which includes inquiries regarding the recent deaths of household members or about the survival of a respondent, example, parents, children, or siblings. Data on household deaths allow estimating mortality over the entire age range, whereas questionnaires about the respondents' relatives yield direct mortality estimates for the specific age groups. Interviews by mobile phones should also remain short. It should be within maximum half an hour, within 20 to 30 minutes, to avoid interruption due to network failure or respondent fatigue. Because network failure is also another issue here. Yeah. Other approaches could be the how large and how frequent should mortality MPS be done. Mm, to help inform the pandemic responses, cross-sectional MPS must be conducted frequently. Preferably every month. Australia is doing like that, and it was observed that it is not very expensive in that sense. The required sample size for each MPS depends on one, the pre-pandemic mortality levels, expected excess mortality during COVID-19 pandemic. Third, local socio-demographic factors, example household size, etc. Fourth, the extent of data disaggregation available. Example, whether we seek subnational estimates from the country level to the states to the districts, etc. And experience from Europe and Latin America indicates that at country level, mortality might exceed pre-pandemic levels by 50 to 90 months. But anyway, that's it. But in India, excess mortality might be lower due to younger population structure, but other factors, example, prevalence of tuberculosis, cardiovascular diseases might counteract this protective effect. So simulation calibrated to match local context should inform sample size calculation in such situation. Next is, where will the pre-COVID mortality baseline come from? Most of the potential modules for a mortality MPS provide information on deaths and person years that occurred over a sufficiently long period in the past to also estimate mortality rates prior to the pandemic. So it is recommended obtaining the pre-COVID-19 mortality baseline directly from MPS data, because this will require asking a respondent to report the month of a death, to one, accurately classify death as having occurred before or during COVID-19 pandemic, to account for seasonal variation in mortality. Internal consistency checks should be applied to verify this baseline is not affected by date displacement or other respondent errors. But having said all these things, there are certain limitations. The mortality data collected by MPS will display errors and biases similar to those encountered during the in-person survey. For example, families with low mortality might be over represented in the MPS sample due to the surveyors or survivor bias, estimating relative increases in mortality during the COVID-19 pandemic, and comparing these estimates across the countries will require statistical models that might at times yield discrepant estimates. So these are the limitations observed while it is being done in other countries, in particularly in Australia. Inferring the number of excess death in a population from MPS data will represent a further challenges. MPS often have a high non-response rate. That is another big issue. this can only be partially remedied by giving airtime incentive to the respondent, because giving airtime incentives found that this dropout rates gets reduced to some extent, and that's also not very expensive in that sense. So to conclude, that in low and lower middle income countries like India particularly, data for civil registration system do not allow monitoring excess mortality during COVID-19 pandemic. That's very clear. So any process of by empirical method or other suggested by some researcher will not work much in India, because they use the where the death registration completeness is 100%. But in India, as of now, it is closer to 50% or little above the 50%, as per 2018 Civil Registration Service report. India, with limited CRVS system, lack information to monitor the effects of COVID-19 on mortality. So rapid mobile phone surveys aimed at measuring mortality trends on a monthly basis could be a realistic and safe option for filling that data gap. MPS have potential to provide such information and thus inform interventions and the programs. With high penetration of mobile phones, because now most of us, everyone has a mobile phones, and limited cost of MPS, frequent mortality MPS should be included in plans to respond to the pandemic in the country. And further, the data generated by MPS can play a key role in better targeting areas or population groups which are vulnerable, most affected by the pandemic. They can also help monitoring the impact of interventions, and as I said earlier, they will help in monitoring the impact of the intervention being done and rapidly identify what works in mitigating the impact of COVID-19. So briefly, this is my presentation, and I look forward to further discussion on this. These are some of the thoughts based on the experiences in other countries are being discussed, talked over here. Thank you very much.
Thank you. Singh Saab.
So any questions from the audience?
Yeah. Can I?
Yeah, please,
Yeah.
sir.
Go
Please,
ahead.
sir.
Hello.
Yeah, please, sir.
Hello, Chairman sir.
हाँ चलिए बोलिए भाई.
Can I intervene?
Yeah.
Yes, thank you. So it's basically a good issue taken up by Dr. J.K. Basu in these challenging times to do face-to-face interviews. So I have three issues, J.K.
Yes,
about the phone service, particularly in India, and that on mortality data. Number one is, you have mentioned all the limitations, agree, but the sample frame itself is a big challenge, because you have mentioned that the data can be obtained from mobile operators or from NGOs, these sources.
Or from any previous service. Yeah.
Am I clear?
Yes, please.
Yeah. So the sources of getting the sample frame, but how safe are these, or how complete are these sources? Number one. And what about the ethical issues? That is one very serious issue. Sometimes we are facing now for the last couple of months for some surveys, not exactly mortality survey, but some other surveys. This is one. And then second, you have of course mentioned the time and also the sample size for getting mortality data. It should be very huge. If you even if you take a death rate of 17 or 18, the base to get the mortality, the incidence to contact the sample size is a big challenge, particularly. So how to challenge this? So in a developed country situation, maybe it is different. But countries like India, particularly rural areas where network is there, of course, you also spoke about the very high non-response rate, which is another challenge. So, are there any mitigation technology or strategies if that will be very helpful?
No, thank you, KVS. What all you have said, it's very pertinent. And some of these challenges are being faced in the developing countries also. I have seen that. Uh, the authenticity of the data, I know because now the many direct marketing agencies and many people are using from the service provider. And when we are you will be using this information or data for a novel cause, I think that could be available and authentic. And also I mentioned that it could also from any previous survey you can take. I understand there has been several surveys I have in the recent times being done by Population Council or many other organizations who used their previous database for mobile phone service. Now, another question what you raised, it's very pertinent on the ethical issues. So, ethical issues maybe before what they do in the developed countries before they conduct the survey, they send a message, a WhatsApp message or any message by any mode, and say that this is such a we got your name is being selected for this purpose, and we want to have a talk on this topic. This is the purpose why we are going to talk to you, and if you give a consent, then we'll go ahead. So, and they give a written consent in that. So, in that way, written consent means they agree, they said agree or don't agree, like that. So that's the way being done over there, but I am not sure how that is possible in our country over here. So that's an issue could be explored. But I am also keen to know, because there are several this phone surveys are being conducted these days during last several months in the pandemic period. So how you are taking that consent and what will be done? So I think that's all. Any other?
Yeah, yeah.
But
These are
but
these are big challenges. Of course, we have very lesser options. But
these are challenges. Why I am bringing these issues, because everywhere in the developed countries and most other countries also, we are getting an estimate and good estimates of mortality due to excess mortality due to COVID-19. The death, not particularly the deaths due to COVID-19, but excess mortality due to COVID-19 pandemic. But in India, we are unable to do that, and they are very simply using the civil registration data, death registration. Their completeness is very higher. Their cause of death information is good. They are using many software and getting it done. But for us, it's being difficult. We don't know. So that's the thought it coming.
yeah.
Sir.
Any question?
Sir, just I have.
Okay, go.
Dr. J.K. Basu,
Yes, sir.
if I am not wrong, I think NFHS2 itself, many people they have used phones. I think in other some big surveys also related to HIV in India. But it is a very handy method which you have shared with your experience through this your presentation, being in Australia and these things. But what about security point of view data? Like that is my concern. Can you throw some light on that?
Security in the number one is that NFHS2, I don't think they have done mobile phone surveys. They might have used in the recent NFHS surveys the tablet. So that is a different. That is a CAPI, computer aided interviews, personal interviews.
Yes.
That is not mobile phone service. This I am talking only over phone talking, not meeting the respondent in person or face to face meeting. How secured is NFHS data? That is secured. This is also secured. You are collecting the information for research purposes only.
But we are very good enough in manipulating so many things in India, particularly.
That we can manipulate everywhere. Not for mobile phone, even for face-to-face service we can manipulate data. That is another issue. This is just I'm thinking of a methodology because I am saying that most of the countries, they are very comfortably presenting, talking even in WHO dissemination or in a higher level bodies that we have, this is our excess mortality due to this pandemic, but we are unable to say that.
Okay.
That's the reason I thought of this thing.
Any more questions by audience? Okay, one more question is there.
Yes,
You
sir.
have already said that there is a big non-response.
Mm-hmm.
So the question is going to arise, who is going to respond you?
Mm-hmm.
And whether it is a random, that is the big thing.
Mm-hmm.
If the data is not random, how you are going to give the estimate there?
Mm-hmm. Yeah, that's definitely a big questions. I don't know, but what I have seen they did in Australia, they while taking the consent, they got an understanding of the expected non-response rate. So based on that, they have calculated. That may be very statistically strong. I agree to that, but at least give a broad idea of this.
Okay. Okay, now the next presenter is sitting there waiting, I think, Arup Kumar Das.
Yes.
Right, you can start. And any more presenter are there?
No, so one is absent. Nandalal Mishra is absent, I think, sir. और उदय दास का भी कोई अटेंडेंस नहीं है. If
Okay.
he is
No,
not
I'm
there,
not seeing him in the audience list.
then
Let us
only
see.
only
Okay.
50% attendance.
Okay, Arup, you can continue. You have a time. Okay. Unlock your mic. Mic, please.
Sorry, sir.
Okay, go ahead.
Am I audible now?
Yes,
Yes.
Honorable Chair, Co-Chair, Singh sir and Khan sir, my co-presenter, and all the participants who presented in this virtual 41th annual conference of Indian Association of Study Population on special issues of COVID-19. So the topic which I have chosen for this session is that global levels and trends of COVID-19 mortality and its policy implication. So when I started working on this topic, uh, that time I was hoping that I will be by the time I'm ready for my presentation, there will be some policy implication. But I would like to say that this is still kind of work in progress, and there is a scope for further improvement on this the policy part. But one thing is that I tried looking at and analyzing this data from a macro perspective.
अच्छे से एप्लीकेशन बना रहता है
Say,
ना, तो फीस भी रहता है.
I request all others to mute their mic so that there is no disturbance for the presenter.
ऐसा रोज ये मंडा बना दे रहे हैं.
I don't know. One thing, Arup, there is a cut on left hand side.
no, I think
कहाँ जाना? किसके?
there is so many.
Okay, go ahead. Maybe that is my problem.
No.
On the left hand side, there is a cut.
कह रहे हैं साला को, अरे उनका कमर उनको पीरियड आ गया है।
Just a second. Who is there?
Okay, okay, go ahead, go ahead.
हाँ, अरे मूव लगा लेंगे, सही हो जाएगा, धूप में बैठ जाएंगे इतना। आप फिजियोथेरेपी करा।
I earnestly request all others to mute their mic. There
Who
is
is
lot of
going to ये
disturbance.
move लगा लेंगे और ये कर लेंगे?
There's some Prince named
Arpit?
Prince.
Arpit,
Prince.
anybody from ICS Global here? Just 1 minute, Arupji. I will try to sort it out. Anybody from ICS Global?
Mintu here.
Mintuji, a lot of
Yes, sir.
disturbance is coming. Can we mute all the other mics?
Yes, sir. I'll do it right now.
Please do, because lot of disturbance. He is really facing lot of difficulty. Arupji, sorry for this. Please go on.
Okay, thank you, sir. Thank you very much. So, as I was saying that I looked at more of a macro perspective. So, just to give a background that I choose this topic. So, as we know that there are huge variations in the mortality rate of COVID-19 across various countries and regions of the world, and the experience suggests that the mortality is high among the elderly population. So, and as a result, we see that the countries which are having a substantial proportion of aging population have experienced high level of mortality. So, this observation leads to the question that whether the demographic composition in a geography is the key determinant of COVID-19 mortality or not. So, this is an observation, and if you see the right hand side box plot chart, you see that we see that of course as the proportion of population 65 years old increases, the median mortality rate has increases from 19 to 242. But at the same time, if you see, there are a lot of heterogeneity within each age group. Even in the countries where more than 15% of the population are 65 plus years old, there also you see that the mortality rate, there is a substantial variation ranging from very high level to a very low level. So the hypothesis that there may not be alone the demographic composition, but also there could be other factor which leading into this mortality. So before going into this, the further continuation, I would also highlight that the mortality, how the mortality, how the it's not going. So can everybody see the data and method slide? Is everybody watching data and method slide?
Yeah, it's
Yes,
visible.
Yeah.
It's
Okay.
visible.
Fine.
yes, we can see
So
it.
yeah. So all I'm trying to say that as we see that there are a lot of heterogeneity in the mortality rate, and even in the highest of demographic has in the countries where higher proportion of the population are aging, like 65%, there also see that there could be lower mortality. So that's the reason for hypothesis that there could be other factors. So in this analysis, I have taken into other factors such as the continent, the region, climate condition, and also the government policy responses in terms of testing. That because as you know, the testing policy of the different countries varies in terms of volume of testing and the type of testing. That sometimes RC-PCR test or other test, and the reporting of the and stringency level. Like Oxford Group has come up with a data set. It's a combination of different measures of lockdown and others measures, which actually captures the summary indicator captures that how stringent the policies of government in terms of lockdowns, closure, all these things are implemented. So that is measured in terms of stringency index. So in addition to demographic composition, We also we looked at other indicators like geography, climate condition, and government policy on testing and stringency level. So, first question is that, as we know that during the pandemic, there are two major challenges related to measuring mortality related to pandemic like this. One of the measure is that if you don't have disaggregated data of age and sex, then any kind of life table or a model like event time model or method cannot be applied to this data. And as you know that this kind of age sex composition is not available of the many of the countries, including India. We don't have age and sex bifurcation of the data, so we cannot see that. And then even the onset of the duration and the final outcome, whether recovered or death, so that kind of time to event data is not available. So uh, only crude way measurement is possible. But another challenge is that the data is generally available, the epidemic data is generally available on date wise, I mean daily case, death, and recovery. So if we want to measure any kind of case fatality rate, there is a lack of correspondence between numerator and denominator, because those who die today may not be those who may not be linked to the number of cases today. So those who infected maybe 7 days or 14 days before, they may be dying. So the relation between the lag between case infection and mortality is not cannot be captured with the daily data which is published. So meaning that case fatality rate, the crude case fatality rate, may not be the a best measure, and more particularly when there are also questions related to testing. But another important thing is the corresponding between numerator and denominator. So another way to do is that identifying some lag. So people say 14 days lag, 12 days lag. I did some correlation analysis, which is a different thing, but at the 12, 14 days lag may be a good proxy for lagged case fatality rate. Another option could be death outcome ratio, like death divided by death plus recovery. That could be an alternative measure. But what I have used here, a mortality, is death per million, case per million, so that we have a million population. So meaning that I have taken total population as a denominator. So the idea is that this gives a more of a kind of stable denominator than other measures of mortality, and an entire population is exposed to that. So that way, so denominator is more stable. So I chose death per million population and other indicator like case per million population and test per million population. Now, the main independent variable, like how I measure the the demographic composition of a population. So one of the things is that, which is for COVID-19 very important, is that what the aging population. But that may not be sufficient. So when I looked at different kind of literature, I found one interesting article, working paper in World Bank. They classify all the countries with demographic change, and in the right hand side top table is actually, if you see that World Bank had classified all our countries into four categories based on growth of working age population between 2015 and 30, and total fertility rate at different point of time, 85 and 2015. And accordingly, if you see that, I don't need to explain elaborate this table. The countries can be classified at pre-dividend, early dividend, late dividend, and post-dividend countries. So in terms of demographic dividend, where these countries are, and it interesting part of this kind of classification is that it talks about the population composition in terms of fertility and mortality, that which level. So for example, post dividend countries are aging population with a very low total fertility rate and shrinking working age population, the post dividend country. Similar, on the other hand, the pre dividend countries are the most kind of demographically backward country, which have very high fertility, mortality, and also a very high working population. So that kind of different extreme. So this is how, so the spectrum of demographic composition can be measured with this kind of World Bank classification. At the same time, if you correlate this four classification with the development classification, like lower income country or high income country, that World Bank classification, there is a high level of correlation, which means that this type of classification itself not only captured the level of demographic transition or demographic composition, but also level of economic development, which is highly linked to health infrastructure and everything. Like, so the post-dividend countries are more likely to be highly economic developed country with a better equipped with health infrastructure. So like America, US, and Italy, and all these countries. So that's the main independent variable. Other independent variable I have borrowed from, like classification of climate zone, because that I borrowed from International Conference on Climate Zone, ICH. uh, uh, and the data source is primarily the ourhealth.com and John Hopkins University GitHub. And I have downloaded this data and converted into using Stata software, converted into analyzable format. uh, and as we know that during the pandemic, like we are in the pandemic, we are in the middle of pandemic. So it is and we have almost crossed almost like a year. So it's a good time to understand the cross section way, the relationship between independent and dependent variable, and what is the level and trend pattern level. At the same time, it is also important to understand the time trend pattern, that how pandemic has shaped over time, how it proceeds, what is the dynamism of. So both the cross section and time series part is used in this kind of analysis. So first, I would like to highlight the cross section part, a little bit of methodology of finding. You see that when I we run a different a number of so we run different a number of ordinary linear regression, ordinary least square regression, with a different dependent variable of death per million, and with the independent variable of this demographic classification, other thing, testing, test case, uh, continent, and climate zone, and also stringent level. And the best model, which is the full model, which I achieved, is R square around 0.89 with AIC 197 and 236, which is the lowest. And second best model also I mentioned that it is also gives a more or less good result. But in this discussion, I have used only the best fit model. And if you see, I also tried see the accuracy level. So that's why I correlated the scattered plot of observed death per million and the predicted or fitted death per million, and you can see that correlation is very high. So the model actually currently represent very nicely the relationship between independent and in a linear form. However, at the same time, I would like to also caution that there could be overfitting, which cannot be tested. I have not tested that overfitting part. So when the new data come, that there is a chance that this relationship cannot be found. So there is of course a chances of overfitting. So I'm not going into that. So based on this linear regression model with a dependent variable death per million and independent variable test per million, case per million, this demographic composition, continent, and climate zone, I'm not showing the regression result, but what we did, we presented a kind of margins mean that this is used using Stata. And what they say that predicted mortality by different independent variable, and also later on interaction. So from the predicted value, if you see, against our common kind of perception that the late and post demographic dividend country are having higher mortality, we see that pre and early countries, those who are also economically backward countries, are more likely to experience a higher death rate than the late and post dividend countries. And can I see, I listen again lot of voices, which is I don't know who's talking. Yeah. Okay. Thank you very
Hello?
much. Yeah.
Yeah.
So what I am trying to say that in the left hand side first graph shows that late and early demographic countries are more likely to experience a higher mortality rate than late and post, which are also economically backward country. Uh, Similarly, the climatic zone, the first, second, and third zone, which are the cold tempered zone, cold and not humid, that cold and dry regions, more particularly one and two. If I go back and see here, which is tempered zone and Mediterranean subtropical zone and hot dry zone, these three zones are more likely to experience a higher death. And in terms of continent, if you see that South America, Oceania, and North America are the highest three continent which are more likely to experience mortality. I also did number of interaction, and with this interaction, if you see that again the more so interaction shows that, for example, early pre and early demographic dividend countries of America, South America, Oceania are more likely to experience higher death. Similarly, if you see the climate interaction between climate zone and the demographic transition level, if you see again, it is quite evident that the areas of those demographic dividend country with a first so cold tempered zone are more likely to experience mortality. Similarly, it also same thing is also observed that it is appearing more or less that the climate condition may have a substantial effect on determining the mortality, not the demographic. Maybe demography is the second. I cannot very confidently say that. So that's so the cross section analysis suggests that there is a possibility that the interaction between the demographic condition and temper the climate condition may be a determinant factor for the high level of mortality. Now, as I mentioned that it is also during the pandemic, it is also important to understand that how this relationship changes over time. So I use a time series model. As you know that there are a lot of challenges in understanding time series model because mean and variances continuously changes over time. So there is a need for achieving stationarity. So that problem is we tried achieving using moving average and also what we call the rolling regression model. So rolling regression model at the so meaning that in every 30 days you run a regression between dependent and independent variable. Where dependent variable I have taken here is the mortality, and independent variable case and test, because that explains majority of the model here. And I run this model under different condition. So and every 30 day I run a regression and store the value of intercept and slope, and then move to the another window period of 30 days. So in this way, at every 30 day during the pandemic period, between dependent and independent variable, you capture intercept and slope, and that you plot in this. So if you see here in this graph, this shows the, the demographic composition wise how the mortality rate has changed. So the left hand pan of the site, which shows that by pre and early demography and late and post demography country wise, rate of change of mortality by case as the case changes over time. So if you see the left part of the thing, that in the pre and early demographic, there is no substantial change in the rate of change of mortality rate. If you see in the left hand pan, however, if you see the right hand part and the post and late demographic dividend country, the intercept, meaning that the intercept level has changed, mean that the level has changed, but the rate of change remain more or less same. And it looks like very, if I don't have not tested, it looks like the mean remains same, but there may be changes in the variation over time in the left hand pan. Similarly, the if I move from demography to the continent wise, a similar kind of observation is found, except for Europe, that in the high mortality scenario, the intercept has changed over time substantially, and more so in the November side. I have taken the data till November 15th. So last side, if you see that there is a huge change in the level of mortality. In the We also looked at the data in terms of the temperate zone and the climate condition of the globe. It appears that the temperate zone has both trend and level effect. The mortality is high in winter than the summer, and the level has increased consistently. So it looks like that the climate condition has both the level effect as well as trend effect. So to conclude and summarize my conclusion, it appears to me that I know that there are a lot of work has to be done in this, that climate change seems to have a substantial effect on COVID-19 mortality after adjusting for other geographic, demography, and policy level factors. So when I looked at the literature, the literature talked very loosely about it, and but there is no conclusive evidence that the climate condition can have an effect on COVID-19, but other vector-borne disease has an effect on climate. Second, my observation is that among the high mortality region, the rate of change of death rate, that is the slope, remains sluggish, meaning slow and volatile, but the level has increased over time. Third, the pre and early dividend country in the country are more likely to experience higher mortality than the post dividend and late dividend country. There is a need for further explanation of the nature of relationship emerged in this analysis for 1 to 2 years for time series analysis to understand what is happening. When I looked at the literature, it looks like that ultraviolet, which is the kind of ultraviolet C radiation related to intervention, may be a potential intervention for climate zone. So in the
এটা দিয়ে দিচ্ছে তোমাকে ওটা লাগবে না আমার ওটা লাগবে না সরি
so
May I
in the
request all others to mute? It is really
so
disturbing, please.
so in terms of intervention, in addition to the current intervention which are going on in terms of mask and hand wash, in the temperate zone, in the low temperature zone, which is the climate zone 1 and 2, there could be a kind of intervention around ultraviolet C relation if this relationship holds true after rigorous research and analysis. So ultraviolet C could be an intervention, and that is possible through uh, air conditioning and creating C radiation in the air condition and other sorts of in the car or in the office place that could substantially kill the virus. So with this, I would like to conclude my presentation and welcome others to. We'll be happy to respond to some of the questions and suggestions. Thank you very much.
Any questions from the audience? Yeah. TVR, go ahead.
Okay. I thought if somebody else is rising instead of me talking. But very interesting and very nice analysis, Arupji. I really profoundly compliment you on that. Very pertinent logging doubt. Now that you said that the climate is the most important variable in the mortality, you think particularly India's COVID, we have experienced after the last winter. Now we are entering the winter almost. You expect higher mortality now, and also this with the nagging doubts of many of us about the data being released on COVID situation and particularly mortality. What is your gut feeling in India?
Yeah, so my gut feeling is that we are not going to because the analysis what is it is appear, it's not only temperature. So if I go back to the slide here, the way it has been classified here, if you see here, the it is about temperature and humidity combination.
Yeah.
So India belong to that hot, humid tropical zone, maybe that kind of zone. So in that, so meaning that the 4th June and 5th June, even in the winter season, they have not experienced kind of mortality. Uh, so I feel that the so I feel that India may not experience very high mortality because of the is the in terms of its latitude and longitude, the location. So that is my gut feeling.
Oh, great. Thank you. Thank you for this.
Can I, Arup?
Yes, sir.
Hello.
Yes, yes.
It's a very interesting presentation you have done, but just because India is being a very vast country, it's a very vast country. It has a different climatic
Climate.
zones,
Mm.
completely different climatic zones.
Yeah, yeah.
So, can you do or further analysis or suggest in your future work that how that varies from if you see that right from Kashmir, Jammu and Kashmir or Ladakh region to the other zone like Tamil Nadu, Karnataka in that side or Kerala. How these things, how the climatic zones has affected the pandemic cases, and not only the pandemic cases, whether that is also related to the recovery rate, that is also related to the disease deaths or anything. So that kind of analysis will be much more interesting. But overall, you have given a very broad idea, thinking what is happening in the other parts of the world and all. So, if your analysis further focus on different climatic zones of the country as such, I think that could give us a more insights and interesting for the policy implication. It will be very helpful.
Yeah, thank you for your suggestion, sir. I completely agree. And actually, when I started looking at the climatic condition data,
Mm,
so each of the continent and each of the country in this data is not only classified into one zone. Even I have seen countries which are which are have three zone, kind of
mm,
that kind of thing. In India belongs to that. But
mm,
for this analysis, for simplification of this analysis, what I did, they have also classified each country into out of, for example, a country is classified into three categories. So they said predominantly this two
mm,
categories. So I took that value.
mm.
That is one limitation of this analysis, because it may not capture the true representation of the climate condition. But I'm looking for the climate condition data. I'm not. But if this kind of data is available, when there are a lot of dimension of environment, uh, if this kind of data is available and at the India level also, so definitely I would like to do this kind of analysis for India and see that is there any change in the mortality and recovery. This is a very good suggestion, and this suggestion is also applicable to the global data and also Indian data. I completely agree, and
Thank
thank
you,
you
thank
for
you.
this suggestion.
That will be wonderful if you.
Yeah.
Sir, Singh Saab,
Ah,
can I add Arup?
yeah,
Sir.
definitely. Go ahead.
Okay, at the outstanding, it is really a fantastic thought you have taken up. I really appreciate you. Especially, I am very much impressed the variable which you have taken, like climatic thing, and it has a significant role to play in COVID-19 mortality things. But in my opinion, as J.K. Basu says, you can take a global data as a reference, and being India as a so diversified country, by all means, we all know that by climatic, by culture, and everything. So starting from Jammu to Kanyakumari, from here Rajasthan to Northeast, can you add one independent variable with climate, urban settlement? You know, urban settlement, like the people are diversifiedly, they are staying in a posh area, extension area, rural area, semi-rural area, semi-urban area, slums, tribal people. So that will again, in it is just in my opinion, you can just think it over. Urban settlement, you can take it as another independent variable and see how it will act. Definitely, I think it will boost the quality in my opinion. But at the most, it is an outstanding presentation and the topic. Even Basu MPS is really going to play a important role. And Arup, can you just think it over on this?
Yeah, thank you,
Thank
sir.
you.
I think
Thank,
a very
thank you,
pertinent
Khan sir.
suggestion. Very pertinent suggestion. I will also try to look at this urban settlement and the condition which are available in census. Also, this kind of information is available for India. We can incorporate that. Yeah, thank you.
Any more questions?
Yeah, this is Rajan. Hello.
Okay,
Yeah,
go
thank you,
ahead.
sir. Sir, uh, really, this is a very interesting presentation. I joined from the methodology part, and I was really. Uh, I have also read the different type of literature, but it was very less in work till now has been done regarding climate in June and sir has also suggested that I was also thinking like similar that because our culture is different in Indian context and climatic condition is different. But if you think the urban rural settlement and uh, rural areas has different means COVID related information, and till now we have we have found that in urban areas are more prominent regarding COVID-19, and that is very good suggestion which is given by sir. So if you can see the climate wise and urban settlement wise, so I think that picture would be very different and will give more information in Indian context. Sir, thank you for this analysis, and it will give us very good information to analyze more in terms of India. Thank you, sir.
Yeah, thank you very much, Rajan. This is very good reflection. Yeah.
Yeah.
Any more questions? Okay, then I have a small clarification, Arup, that is
Sir,
very
sir.
small for you. Definitely, it is a nice presentation, and what Khan Saab said is very important. You can see by the population density also, right? So definitely in the urban areas, it is hitting more, and the mortality is also more. Everywhere, where everyone is saying that this is all your internal thing, and the aged population is more affected, and immunity is going to be, you see, a big factor. But you are saying that it is a climate condition. And if you see the Indian condition, you said that low temperature and less humid, they have high mortality,
Right,
right?
right.
Now go to Maharashtra, high humid, right?
Mm,
And temperature is also
yes.
not very low. Still mortality is high.
Mm,
Almost same situation in Kerala,
mm,
right?
mm,
Humidity is there, temperature is almost same, mortality is very low.
true.
So there are different more factors are affecting that, not only this. So I think one has to go through many more, include many more factors. In the same country, if you go from here to there, come to UP and Bihar, right? And you may be knowing that Bihar is doing, Arup, you know better than me. Still, their mortality is very low.
Mm,
What do you want to say about that? So something is going on. I don't know about COVID-19. I have not, actually, I have not worked on COVID-19 much and not seen much literature, but something is going on. If you see the differences, so that is not all climate thing, right? So this is my, you see, my thinking.
yeah.
Maybe I am wrong. I don't know. So
No, sir, I completely agree. And there is opportunity for including other variable. My initial response is that I looked at some of the indicators which when I was just playing with the data. unfortunately, these relationships are not very straightforward. So, for example, like density of the population, the density of the population, that also looked. Of course, infection depends on that, but mortality not very clear. So one of the challenge with developing this kind of models are when you more variable you include your and with a more missing value is added into the model, because when I looked at a 2203 country data, and if I include testing data, immediately the data is shrink to 184. The sample
Yes,
size reduces. Again, I
definitely.
include another variable, so that's going to 100.
Right.
So I think that I completely agree. But yeah, I think I would love to include other variable very systematically and see the how the model looks like. And definitely, I'm looking for collaborators and guides. So I would love to come back to you and take your suggestion on this.
Okay, thank you. Thank you, Arup.
Thank you, sir.
Any more questions, or we just want to close it?
Close कर
Yes, sir. Let us close
So,
if you permit.
first of all, I am thankful to the two presenters who have given a nice presentation. So, by virtual, we give a big hand to them. We clap them and for nice presentation. And Arup, you have, you see, given a nice presentation, gone and looked on the data of many countries. And J.K. Basu also, he is going to look onto that. So both are different approaches. So I am thankful to both of them for a nice presentation, on time presentation. Thank you all very much. खान साहब कुछ
Thank you.
कहना चाहते हैं?
नहीं सर, बस आप कहने के बाद हमारा क्या है, बस आई टोटली एग्री विथ यू. बस दादा को भी हाय कहना चाहता हूँ. आरोप,
Thank you,
बढ़िया
Khan
बढ़िया
sir.
बढ़िया थी.
Thank you, sir.
सिंह
Thank
साहब
you,
आपने
everybody,
टाइम
for
निकाला, मुझे
participating.
अच्छा लगा. थैंक यू.
Thank you. So
Thank you,
so
everyone, for
so
good suggestions.
so
Thank
my
you, sir.
so
Thank
I
you, sir.
have a formal duty to formally thank the chairperson. Thank you, Professor K.K. Singh ji, for chairing this session, and I also thank friend Dr. A.G. Khan for co-chairing this session. And as chairman and co-chair said, these are very beautiful papers, good papers. I compliment both the presenters. Thanks so much. Thank you all the participants. Now, after this, after a small 5-10 minutes break, please join in hall 1, where we will have the last technical session. And then there is an invited lecture that is being given by Professor Srinivasan sir. And then we will be going to the valedictory.
Okay.
Thank you. Thank you so much.
Thank you.
Thank you, sir.
We are waiting in hall 1. Please join us.
Yeah.
Thank you, sir.
Dr. Venkatesh Srinivasan has come. Professor Srinivasan is also there.
So, come to Chennai for अच्छा, सोमेश जी.
Yes, sir.
ये कौन है co-chair?
You are co-chair Tiwari ji. Who is the co-chair?
Anil Chandran है.
Anil Chandran. Anil Chandran. Anil? He is there. Anil Chandran.
What we will do, Anil, I will, just speak of the topic for the session. Okay. And I do not know the participants. So what you do is you go ahead after that and you introduce each speaker, participant speaker, whatever extent that you know, or ask them to introduce themselves and go ahead with the topic. Okay. Then we go to the next presenter and so on. Yeah. And after that you can make your observations. I will make some observations and find out. So what is the time? How many papers are there to be presented? I think we have four papers. Okay, 10:30. Let us say we start around 10:35 or so. 10:40. I think one more will come, sir. Actually, one lady she could not present in the first session. She wanted to present it in this session. In fact, we made he requested her to make. No, that's okay. No, don't give me the. So only 5 papers. Five people. 1 hour. Let us say. Yeah. Introduction, presentation, all will take away. So 5 people.
10 to 12 minutes.
10 minutes will be fine, sir. Yeah, because 15 minutes. Yeah. 10 minutes. Yeah. And then they will over and see. Yes. So, and ask them to be very precise. I don't say that in the initial. Yes. And ask them to bring to fore. Well, I will say that you don't have. Yes. Ask them to bring to fore some programmatic policy implications.
Yeah, I think, that's true. In the previous session also, that was completely missing. I said that, you do regression and all fine. But what are the program policy implications, recommendations, that you have to link it with the program inputs.
Absolutely. So
otherwise,
the researcher, what do you bring to fore for the program people to take cognizance of?
Yes.
For observant of for the future, so that's what we should be looking at. Okay, so what is the participant list? Are they there?
That Ranil, can you read out the list?
Yes, I'll do that.
Yeah. Sir, you are in Delhi or where are you now? Delhi, na?
Sir, we have the first paper by Anjali Bansal. Is she there?
She is there.
Of compensation. Okay, second paper by Arpit Singh. Is he there? No.
Arpit, are you there?
No.
Seems to be not there.
Okay. Third one. Next one is Aishwarya PV. Is he there? These young people are the last to come. All the oldies starting.
Sir, excuse me. Yes, what happened? There were some presentations in hall 2, and they are shifting to hall 1 now. So it will take a couple of minutes. So you can start, and people will join.
Okay. Let us at least have 2 people. Who is the third one? Who's the third paper?
Anjali is there, no?
Is there?
Anjali Bansal, are you there?
Yes, sir, I'm there.
Yeah, she's there.
Okay, then let's start. At least there are 2 of them. Yeah. Okay. Okay. Here, sir, some introduction.
Yeah. So I thought it is already done.
No.
Otherwise, I'll be very happy to do
We are waiting for you to do that.
Yeah, indeed a great pleasure to have Dr. Venkatesh Srinivasan from UNFPA to chair this session. Always he has been a great source of inspiration to IASP and lot of help. Thank you, sir, for accepting the invitation to chair this session. I welcome you. I have pleasure in welcoming our friend Anil to co-chair this session. I invite all the participants to present their papers. Thank you very much. All yours, sir.
Thank you, Xavier, and good morning to all the participants. Starting with my respects to the senior members, the faculty, and best wishes to the participants who are here. I'm glad to see that there are at least 30 odd participants for this session. I deem it an honor to be chairing this session, which is a very relevant one, where we have very good presenters that are sharing their analysis and inferences and foresights on the different aspects of family planning and reproductive health. I'm very glad to see that there are papers on infertility, which is a very important issue, which is still not very well addressed in the program in our country, and which is also a major issue of gender-based violence that women face. There are issues of compensation of family planning and other relevant papers. So as I was sharing, I do not know how many of you had heard me saying earlier. I would personally, all the papers are going to be really insightful for me, but I would be very personally grateful if you could share implications of your analysis for future policy and programming, because there is a big divide between the research community and the practitioners. And
लक्ष्मीकांत जी हैं क्या भाई?
try to bridge that gap to the extent possible. On the timing and other details, Dr. Anish Chandran, my co-chair, will elaborate, and he will.
Dear all, please go to hall 1.
We will have all the presenters sharing their presentation, and then we will have some questions. On the questions, I think.
Dear all, the session is over now in hall 2, so please go to hall 1.
Putting your observations or questions into the chat box.
How to go in hall 1?
And I hand over to Dr. Anil Chandran to take forward the sessions and initiative. Thank you.
Thank you, sir. So we have 4 presentations in this session. Though probably one or two may not be there, but that we will come to know probably a little later. But I think as of now we will go with the view that there will be